Welcome to another lecture by MedicoMedics. Inflammation, a complete lecture. Now, what is inflammation really? In this video, we will cover the cardinal signs of inflammation, talk about acute versus chronic, discuss outcomes, systemic effects, discuss drugs that target inflammation. For those who are curious, we will also deep dive into key pathways, and as always, end with a summary. Now, inflammation is the body's frontline defense against harmful stimuli like infection or tissue injury. So it's a protective response to eliminate the initial cause of cell injury and initiate tissue repair. Now, we have acute inflammation and we have chronic inflammation. Acute is typically characterized by a rapid onset, a short duration, seen, for example, in appendicitis. In chronic, it is more persistent, low-grade inflammation, seen, for example, in rheumatoid arthritis. Now, recognizing whether inflammation is acute or chronic helps us guide both diagnoses and treatment. Now, the 5 classic signs of inflammation, also known as the cardinal signs of inflammation, include redness, heat, swelling, pain, and loss of function. These are the so-called hallmarks of an acute inflammatory response. And this isn't just theoretical. So these signs, they show up every day in clinical medicine. When a patient presents, for example, with a swollen, warm, and painful joint, such as in gout or septic arthritis, for example, you are directly observing these inflammatory mechanisms at work. Now, the redness and heat part of it, they are caused by vasodilation. So primarily, this is mediated by histamine and prostaglandins. These increase blood flow to the injured tissue. So that's why we get heat and redness, vasodilation. This also explains the flushed, warm appearance of an inflamed skin. Then we have tumor or swelling. This results from increased vascular permeability, allowing plasma proteins and fluid to leak into the interstitial space. A process mediated again by histamine and by endothelial contraction. Then we have pain. Now, pain is triggered by bradykinin and by prostaglandins, which sensitize nerve endings. This is why inflamed areas are tender, and also why non-steroidal anti-inflammatory drugs like NSAIDs and steroids, these block prostaglandin production, leading to the relief of pain. Finally, we have the loss of function. This arises from both structural damage and pain-mediated disuse, and can be clearly seen in inflamed joints or in impaired organ function during severe inflammation. So, what's the clinical relevance here? Well, these signs are essential for bedside diagnosis. Whether it's the red, hot joint of acute gout, for example, or the swollen finger in cellulitis, or the loss of function in a stroke caused by vasculitis, recognizing these patterns of inflammation allows for rapid and accurate clinical reasoning. Now, before we continue and deep dive into the differences between acute and chronic, let us just talk about the outcomes of inflammation. So, inflammations can resolve. From an abscess, for example, we can have scarring happen, or it can progress to a chronic state. A patient with pneumonia, for example, may recover completely, or develop a lung abscess requiring drainage. In a myocardial infarction, inflammation leads, for example, to fibrosis, which weakens heart function. So knowing about these different outcomes helps in clinical decision making. Now, let's start with the, let's say, best one, which is resolution. Resolution occurs when the inciting agent is cleared, right? The cause of the inflammation is now cleared and the tissue is capable of regeneration. For example, here we could mention a superficial skin cut that is promptly cleaned and uninfected and can heal entirely without any residual damage. This process depends, of course, on intact basement membranes, limited tissue destruction, and efficient macrophage-mediated cleanup. So in this ideal outcome, normal structure and function are fully restored. Now, let's move on to another one, which is abscess. So abscess formation represents a localized collection of pus, so dead neutrophils, bacteria, tissue debris, etc. And typically, this is presented in response to a strong neutrophilic response to infection. A classic case is we can take a staphylococcal skin infection or a lung abscess after aspiration pneumonia, for example. See, abscesses are walled off, but not resolved by the immune system alone. They often require surgical drainage or antibiotics. So they illustrate how inflammation can contain but not eliminate infection. Another one is fibrosis. So fibrosis results when tissue repair involves collagen deposition instead of regeneration. This especially after significant damage or when regenerative capacity is limited. After a myocardial infarction, for example, dead cardiac muscle is replaced by scar tissue, which restores structure, right, but not contractile function. And this type of healing prevents rupture, which is good, but can lead to long-term organ dysfunction, such as heart failure or restrictive lung disease, etc. And finally, we have chronic inflammation. This occurs when the stimulus persists or the immune response fails to eliminate it. Diseases like inflammatory bowel disease, for example, like Crohn's, it shows how ongoing inflammation leads to cycles of tissue damage and repair, with granuloma formation, strictures, and eventually fibrosis. So chronic inflammation also underlines autoimmune diseases, even cancer risk, and even, of course, progressive organ failures. So now that we've looked at the different possible outcomes of inflammation, let's now dive into the differences between acute and chronic. Now then, let's deep dive a bit into acute inflammation. So the key cellular players here include neutrophils, mast cells, and macrophages. The neutrophils are the first responders, mainly killing the microbes. The mast cells release histamine, leading to vasodilation and permeability. And if you remember the cardinal signs, here we find swelling and heat. Now, the key mediators. We should also mention macrophages involved in the cleanup and the release of cytokines. Now, the key mediators are histamine, prostaglandins, bradykinin, and interleukin-1 and tumor necrosis factor alpha. So histamine increases vasodilation and permeability. The prostaglandins trigger the fever and pain. Bradykinin, same, pain and elevated or increased permeability. Interleukin-1 and tumor necrosis factor alpha, fever and endothelial activation. And you can probably identify the cardinal signs here. Now, Since we know then that acute inflammation is driven by cells like the neutrophils and mast cells and the chemical mediators like histamine and prostaglandins, these all responsible for the heat, pain, swelling, etc. that we see in infected wounds or in allergic reactions, etc., in the inflammatory process. Knowing that, what we do clinically is that we target these mediators with drugs. For example, NSAIDs, or non-steroidal anti-inflammatory drugs, they block prostaglandin synthesis, for example. So this one gets blocked. And this will then lead to the decrease or reduction in fever and pain. So the mediators, right? This is high yield. The mediators here are the drug targets. We mentioned NSAIDs block prostaglandins. Antihistamines block, well, histamine. Anti-tumor necrosis factor drugs will then target tumor necrosis factor alpha. We use it, for example, in the treatment of Crohn's or rheumatoid arthritis, etc. Now let's take a look at a few more examples. So taking a closer look at acute inflammation, we mentioned we have key cellular players and key mediators. And we focused on the mediators because these are the targets of our drugs. So the whole purpose is to block these different mediators, to decrease the mediator effect, all in all to reduce inflammation. Let's take a look at, for example, acute appendicitis. So acute appendicitis is triggered by obstruction of the appendiceal lumen, often due to something like lymphoid hyperplasia or something, leading to bacterial overgrowth and neutrophil infiltration. It's usually a textbook example of acute inflammation. It has the classic localized pain, fever. On labs, we see neutrophilic leukocytosis, etc. Another one is bacterial pneumonia. It causes alveolar exudation and infiltration with neutrophils, leading to consolidation of lung tissue. And streptococcus pneumonia, I think, is the most common cause. And the classic findings here include fever, productive cough, low bar opacities on imaging, etc., etc. Another one is acute gout attack. So gout flares are driven by uric acid crystal depositions in our joints, which activates the inflammasome and recruits neutrophils. And we will see the classic signs of red, swollen, intensely painful joint. It's often on the big toe, and it has a quite rapid symptom onset. We do have a lecture dedicated to gout, so check that out. Now, what about chronic inflammation? Well, chronic inflammation sets in when the acute phase couldn't clear the problem. Over time, this leads to tissue damage and fibrosis, so some of the outcomes we discussed previously. And chronic inflammation is a key driver in autoimmune diseases like lupus, or it contributes, for example, to cancer in conditions like Barrett's esophagus. A classic example is tuberculosis, where granulomas wall off infection, but can also damage lungs. Why is it clinically relevant? Well, of course, chronic inflammation contributes to organ damage in autoimmune diseases, for example. And it's involved in the elevation of cancer risk in diseases like ulcerative colitis, for example. Now then, let's move on to discuss some examples of chronic inflammation. Let's begin with vasculitis. So vasculitis is inflammation of blood vessel walls, often triggered by autoimmunity or immune complex deposition, leading to ischemia and multi-organ damage. Now, it is a direct example of how chronic inflammation targets vascular structures. Another example is rheumatoid arthritis. So, rheumatoid arthritis is a chronic autoimmune disease where persistent synovial inflammation leads to joint destruction and systemic complications. And as you can see in the illustration, the inflammatory process is driven by cytokines like tumor necrosis factor alpha, interleukin 1, for example, making it highly responsive to target with anti-inflammatory therapies, because these are the mediators we talked about. Another example is Crohn's disease, which involves chronic transmural inflammation of the GI tract, so the gastrointestinal tract. Often, it's with granuloma formation and skip lesions. It's a classic example of dysregulated intestinal immunity leading to chronic inflammation, further to fibrosis. We can look at systemic lupus erythematosus, or just lupus. Now, lupus is a systemic autoimmune condition where immune complex mediated inflammation affects multiple organs, including skin, joints, kidneys, and even the central nervous system. Its hallmark is widespread chronic inflammation driven by autoantibodies and complement activation. And finally, we can take a look at celiac disease. So it's an autoimmune condition triggered by gluten, leading to chronic inflammation of the small intestine, or the small intestinal mucosa, to be more specific. And it's characterized by villous atrophy, crypt hyperplasia, lymphocytic infiltration, resulting in malabsorption and extraintestinal symptoms. Now, we didn't deep dive here into these different pathologies, but make sure you check our pathology series, where we have dedicated lectures on all these pathologies. And if you can't find one that you are looking for, please drop a comment. Let us know that you would like to request a lecture on that specific topic. Now then, we move a bit more into the details of inflammation here, looking at the systemic effects of inflammation. Now, inflammation doesn't just stay local, right? It causes systemic effects like fever and changes in your blood values or markers. You get high CRP or ESR, and this tells us that there is an active disease ongoing. We can see a left shift in the white blood cell count, and this can help us recognize an early infection or even leukemia, etc. And in sepsis, for example, these markers are essential for tracking progress. Now, knowing that blood markers correlate with the inflammatory processes, we have to dive a bit into the mediators we talked about and see how we can actually follow this in a laboratory environment. Let's begin with fever. Now, here, cytokines like interleukin 1 or tumor necrosis factor alpha, they are released by activated immune cells, right? And they will travel to the hypothalamus. There, in the hypothalamus, they will stimulate the production of prostaglandin 2. And prostaglandin 2 raises the hypothalamic set point for the body temperature. So these cytokines affect the hypothalamus with the mediator prostaglandin 2 or prostaglandin E2. This tells the hypothalamus increase the set point for the body's temperature. Essentially, elevate our body temperature. And this is then what we see as fever. Now, the clinical relevance here is fever is often the first systemic sign of infection or inflammation, and it plays a protective role by inhibiting microbial growth and enhancing immune function. But, of course, it can also signal serious conditions like sepsis or autoimmune flares or malignancy, etc. Here we would use antipyretics or for example, like NSAIDs, so non-steroidal anti-inflammatory drugs. And if you remember from previous slides, the mechanism here was to block prostaglandin synthesis. So by stopping this, we get the reverse effect, which means fever or body temperature goes down, so we decrease fever. We also call these drugs antipyretic. Now, next we have acute phase reactants. So here the key proteins are CRP, we have fibrinogen, and ferritin. Now, CRP, which is C-reactive protein, it rises rapidly in inflammation, and we use it to monitor disease activity, for example, in rheumatoid arthritis or infections. Fibrinogen increases our ESR by causing red blood cells to stack. Ferritin sequesters iron to limit microbial access, so it's a sort of defense mechanism by the body. What do we see as decreased? Well, albumin and transferrin. And the synthesis of these is reduced during inflammation to redirect sources toward the acute defense. Clinical relevance here? Well, elevated CRP and ESR are routine inflammatory markers used in everything from infection monitoring to autoimmune disease activity. A high ferritin level, for example, may signal inflammation or macrophage activation syndrome. And these labs here are crucial for diagnosis and tracking response to a certain treatment. So we monitor these. Number 3, we have leukocytosis. So in response to the cytokines like interleukin-1 and tumor necrosis factor alpha, our bone marrow increases white blood cell production, especially neutrophils. When we say often with a left shift or band cells, it means we're talking about immature neutrophils that are released into circulation. So in response to the interleukin-1, for example, and tumor necrosis factor alpha, we had the synthesis of prostaglandin. Prostaglandin E2 tells the hypothalamus, elevate the set point for inflammation. Result, we get fever. In our blood, we see the elevation of our C-reactive proteins. We see ESR increase. And in our bone marrow, we see the sudden or elevated increase of white blood cells, specifically neutrophils, often with a left shift, meaning they are immature. So we have a sudden release of a lot of immature white blood cells or neutrophils. All of these are markers for ongoing existing inflammation. So leukocytosis here indeed is a hallmark of acute infection, but can also be seen in inflammation in general. So, for example, tissue necrosis, seen in myocardial infarction, or hematologic malignancies, for example. So, again, I've seen many medical students struggle here, but let's clarify it one more time. The left shift here suggests that the bone marrow is under stress or it's responding aggressively. So it's pumping out these immature neutrophils. And all of these are commonly tested in the context of infection, sepsis, or leukemia workups. So all of these mentioned, these systemic inflammatory responses, they're all key diagnostic tools for us. So fever, CRP or ESR elevation, white blood cell changes, of course, they are often the first clues that an inflammatory or infectious process is underway. Understanding these mechanisms helps distinguish between infections, or if it's autoimmune, or if it's malignant, etc., causing these systemic symptoms. Now then, let's move to the more advanced and detailed part of the lecture, where we talk about drug mechanisms and pathways of inflammation. So, we begin by talking about some drug classes, starting with NSAIDs. Now, NSAIDs, or non-steroidal anti-inflammatory drugs, they work by inhibiting cyclooxygenase, or COX, enzymes. This leads to reducing prostaglandin synthesis. And by releasing or decreasing, to be more exact, decreasing prostaglandins, if you remember, this will then lead to a decrease in pain, fever, and inflammation. Some examples of NSAIDs include ibuprofen and naproxen. Now, NSAIDs are the first-line drugs for inflammatory pain, but chronic use can actually cause gastrointestinal ulcers and kidney damage. This is due to prostaglandin suppression in protective tissues. So even if it's an important mediator here involved in fever and pain and we want to decrease it, it has other functions. Next, we have steroids. So steroids block phospholipase A2, or PLA2 here. And this prevents the release of arachidonic acid. And we're going to talk about what that is shortly. Now, they also suppress many other cytokines. So the steroids, this is what makes steroids very powerful anti-inflammatory and immunosuppressive agents. We use them in asthma, autoimmune flares, even in transplant rejections. However, with a lot of good, there is always some bad. So long-term use comes with risks like immunosuppression, osteoporosis, adrenal suppression, etc. Then we have anti-tumor necrosis factor agents like infliximab. So they block tumor necrosis factor alpha, which is a key cytokine in chronic inflammation. And these drugs are used in diseases like rheumatoid arthritis, Crohn's disease, psoriasis, for example. And while they are very effective, they increase the risk of infections, particularly tuberculosis reactivation. So you have to make sure to screen the patients. Finally, colchicine inhibits microtubule polymerization, further reduces neutrophil migration and activity. So it's mainly used, for example, in treating acute gout and familial Mediterranean fever. Since it works downstream of cytokine release, it's especially useful in conditions where neutrophil-driven inflammation is more dominant. Now, let's take a look at some key pathways. So beginning with the arachidonic acid cascade, or the arachidonic acid pathway. Now, it begins with phospholipase A2 liberating arachidonic acid from cell membranes. This arachidonic acid that is then converted by these cyclooxygenase enzymes, or COX enzymes, leading to the activation of prostaglandin G2, seen here or prostaglandin in general, which then elevates the inflammatory symptoms like vasodilation, pain, fever, etc. Furthermore, it also is converted by lipooxygenase enzymes to neutrophils. No, that's not right. Leukotrienes. And these then lead to, for example, bronchoconstriction. Now, this pathway here, right? This is the main target for the NSAIDs we talked about. So the first group here, like ibuprofen. Furthermore, they're also the main target for steroids. And we also have leukotriene or leukotriene inhibitors like, I think it's montelukast, something like that. We use it in asthma. So anyway, the arachidonic acid cascade begins with phospholipase A2. It liberates arachidonic acid from the cell membranes. This is then converted by these key enzymes to prostaglandins and leukotrienes, and they have the inflammatory effects we then see. Now, the drugs we use here are to block these mediators, so stop it right here. Then we have toll-like receptors, pathways. These recognize microbial patterns like LPS on bacteria. So activating the transcription factor, this will lead to expression of inflammatory genes like tumor necrosis factor alpha, interleukin 1, interleukin 6, for example. And these toll-like receptors are essential in innate immunity. Then we have inflammasome, so a cytosolic sensor complex that activates caspase-1. And caspase-1 here activates interleukin 1 beta, which is a very potent pro-inflammatory cytokine. And overactivation of inflammasomes is implicated in autoinflammatory diseases like familial Mediterranean fever and NLRP3 associated syndromes. Excellent. So in summary then, inflammation is a protective immune response to injury or infection. We have acute, which is rapid, often neutrophil driven. We have chronic, which is persistent, usually involves macrophages and lymphocytes. The cardinal signs, we had redness, heat, swelling, pain, and loss of function. Key mediators, histamine, prostaglandins, bradykinin, cytokines. Outcomes, we can have resolution, we can have abscess formation, fibrosis, or a persistent chronic inflammation. Systemic features included fever, elevated CRP and ESR, and leukocytosis. And if you remember, often with a left shift. We use anti-inflammatory drugs, and these drugs target the mediators. So we have NSAIDs, these are the so-called COX inhibitors or cyclooxygenase. We can use steroids for phospholipase inhibition and anti-tumor necrosis factor agents, and we had calcitonin. And that's the end of this lecture. Thank you for listening.